and welcome to Conversations in Interventional Cardiology. My name is Suzanne Baron, and I'm one of the deputy editors at SCAI, and I'm honored to represent SCAI and the editor-in-chief, Dr. Alexandra Lansky. We're here today to discuss a recent study that was published in SCAI entitled Temporal Trends in Transcatheter Aortic Valve Replacement in Isolated Severe Aortic Stenosis. Now, I'm joined by an esteemed panel of leaders and experts, including Dr. Tanush Gupta from the University of Vermont Medical Center, as well as Dr. Harold Dauerman, also from the University of Vermont Medical Center. Both Dr. Gupta and Dauerman led the analysis that we'll be discussing today. And we also have Dr. Micheal Reardon, the Surgical Director of Structural Heart Disease at Houston Methodist. So thank you all so much for joining this conversation today, and I'm going to turn it over to Dr. Gupta to give us a short overview of his findings.
Great. Good evening. I'm Tanush Gupta from the University of Vermont. On behalf of my co-authors, I thank SCAI for the opportunity to present our study titled Temporal Trends in Transcatheter Aortic Valve Replacement for Isolated Severe Aortic Stenosis. As background, the 2020 ACC-AHA Valvular Heart Disease Guidelines recommend surgical aortic valve replacement as a Class 1 recommendation in patients younger than 65 or those with life expectancy more than 20 years. In patients aged 65 to 80, either surgery or TAVR are recommended as Class 1 recommendation after a shared decision-making conversation with the patients. And in patients greater than 80 or with life expectancy less than 10 years, there's a Class 1 recommendation for TAVR. Using the Vision clinical database, our group previously demonstrated a dramatic growth in TAVR utilization in patients less than 65. In 2021, 47.5% of the patients less than 65 receiving isolated AVR underwent TAVR. In contrast, data from French and Danish national registries have shown more modest growth of TAVR for severe AS in younger patients, with less than 20% undergoing TAVR in 2020. We hypothesize that there are national differences in practice patterns and that TAVR utilization in younger AS patients has continued to grow in the US. So the data for this study were obtained from the Northern New England Cardiovascular Disease Group database. We identified all patients who underwent TAVR or isolated TAVR for aortic stenosis. Our cohort included approximately 6,700 patients. The exclusion criteria were concomitant procedure, emergent procedure, endocarditis, or prior aortic valve replacement. Temporal trends in TAVR and SAVR were identified in the 3 guideline stratified age groups. Lastly, we use multivariable logistic regression analyses to identify the independent predictors of TAVR in younger patients less than 65. So looking at temporal trends, in patients less than 65, the relative utilization of TAVR grew from 19% in 2016 to 51.7% in the most recent study year. In patients less than 65 to 80, the relative utilization of TAVR grew from 42.1% to 85.8%, whereas in patients more than 80, TAVR was nearly universally utilized throughout the study period. Well, people argue that we know that young patients are getting TAVR, but young age does not equate low risk. When we looked at STS-PROM risk in younger TAVR recipients less than 65 years old, we found that most of these patients were at low risk as estimated by STS-PROM. The proportion of patients with the STS-PROM less than 4% was 55.5%, 55% in 2016 and grew to approximately 3/4 in the more recent study year. Lastly, looking at the multivariable predictors of TAVR, the age, vascular disease, diabetes, heart failure, chronic renal failure, home oxygen use, prior MI, prior PCI, and prior CABG were predictors of TAVR use, whereas bicuspid aortic valve disease and class 4 and YHA status were predictors of TAVR. In conclusion, we demonstrate a continued increase in utilization of TAVR in younger adults less than 65. In 2022, TAVR was utilized in more than 50% of the patients less than 65 undergoing isolated AVR. This growth is largely driven by increased TAVR use in patients at low surgical risk, as estimated by STS-PROM. These practice patterns in Northern New England might not be reflective of the national US practice. Also, these temporal trends data are in no way an endorsement of TAVR utilization in young. our findings do have important implications for lifetime management strategies, as a majority of these young TAVR patients will require an aortic reintervention. Thank you for the opportunity to present.
Well, thank you so much, Dr. Gupta, for sharing your findings. Definitely thought-provoking. I'm going to throw the discussion over to Dr. Reardon. Dr. Reardon, you are a surgeon. What are your thoughts seeing this data?
Well, I think that this represents evidence that there are poorly functioning heart teams out there. Half the people that are less than 65 should not be getting TAVR because they're low risk. And it goes against our guidelines. And the fastest growing operation for surgeons right now is TAVR explant and surgical valve replacement. And this is going to grow further. And we know that that carries 2 to 3 times the hazard ratio of just doing a redo AVR. And so I think these patients are not being very well counseled on what their options are. Clearly, European have different guidelines, with the line drawn at 75 and not at 65, and no mention of how long you're going to live, just mention of risk. But, if you look at the low-risk trials, and I had the opportunity to run Evolute low risk with Jeff Popma and now John Forrest, only 7% of people were less than 65, and only 1.2% were less than 60. So we really don't have data on these people. And if you really do think that you have a healthy 65-year-old, they're going to live about 20 years. It's a problem if you do a TAVR, particularly if they have low coronaries and small sinuses, because they're not going to get a second TAVR. They're going to get an explant. So I do worry about this. I think that this is really places where there probably is not a reasonable surgical input or reasonable understanding of the randomized low-risk trials.
So I think that's a really important point. And let me throw this back to you, Dr. Gupta or Dr. Dauerman. Do you have a sense of, what the volumes are and the heart team makeups were from the centers from which you derived this database? Are these high volume centers? Are these centers that are doing, have, well-formed heart teams? And do you think, you did mention as one of your limitations is maybe this isn't reflective of across the U.S. Do you think there's something that's different in the practice patterns in northern New England?
Well, I'll take that, Suzanne, first. So the background to this study is that we did a national study using Vizient, where for sure it's representative of national practice because there's no one location or region or one size heart team that was included in the study. Vizient includes over 300 medical centers in the United States that showed the same thing. But then putting on my other hat in JACC, we published a paper from France, which showed something a little different than what we found in Vizient in the US, where instead of the majority of people under 65 now getting TAVR, only about 20% in France were getting TAVR, while 80% were getting SAVR. Still a significant growth over time. So this led to the question, did we do the analysis wrong from Vizient? Or did we somehow have a different definition of something? But, using age categories, it's hard to mess up the definitions of ages. So I asked Tanush to work on this with me to take centers where we could get really granular on the data. So these are only centers in Vermont, New Hampshire, and Maine. These are all high volume centers where we know the compositions of the heart teams. And we found exactly the same thing in just northern New England that we had found in Vizient. So I was pretty sure we were right when we did our Vizient analysis, and that what we were discovering was there's international differences in adoption and the use. Like Dr. Reardon says, European guidelines are different than the US guidelines, and maybe the guidelines do have an impact. I would like to comment about the guidelines as someone who does clinic every Monday, sees structural heart patients with a heart team, with a cardiac surgeon. I can't follow the guidelines. I have never once calculated a patient's life expectancy in clinic, ever. I don't know anybody who has a calculator that says this person has a 20-year or a 10-year life expectancy. I can calculate their age or their SCS risk, but I'm always doing just sort of a judgment call about that. Are they going to live 20 years or more? So I think the guidelines are not really being applied, as Dr. Reardon was saying, But part of it is that it's just not part of our clinical practice to estimate how long people live when they come into our office.
So I'll ask the provocative question. Do we need to talk about changing the guidelines? Is, with this data that you guys have shown and with the caveats that Dr. Reardon very appropriately said, which is that we're going to be dealing with the lifetime management of these patients. Many of them are going to need a valve reintervention. Some of them may not be able to get TAV and TAV, depending on what their anatomy is. Is there something we need to do or start to push for to kind of put a stem to the growth that we're seeing? Do the guidelines need to change? I'll start with you, Dr. Gupta.
Well, I do not think these data support change in guidelines. Of course, these are practice patterns, trends data. So the answer to that question is no, we do not have the data yet. Should there be a trial in patients, aged less than 65, with a follow-up up to 10 years? Probably yes. And I think that would be needed to change the guidelines. One thing I would say to counter Dr. Reardon is that, this could be reflective of heart teams that are not well functioning, or it could be reflective of heart teams that are functioning very well. Because as we know, STS PROM is a very inaccurate predictor of patients. It's a predictor of their mortality risk, but it doesn't truly measure their morbidity risk. And there are multiple things, including the socioeconomic factors, including, need to go to work quickly, and things like, morbid obesity, the upcoming non-elective surgery, which all these things go into play in decision making. And we see that a lot of patients, even after extensive counseling, do opt for TAVR. And I think if the anatomy does suggest that they could be an optimal candidate for redo TAVR, it might be a reasonable option. But of course, our data do not show that. But I think more needs to be done in this space.
Dr. Reardon, your thoughts?
Well, of course, STS data doesn't really reflect what happens in TAVR. It reflects what happens in surgery. And there are clearly some people that are less than 65 who are at higher risk and aren't going to live that long. Because I look at everybody and I try to figure out how long they're going to live. I don't have a calculator. I can tell you what the U.S. census data says for men and women, but I have a good idea about how long people are going to live. And I, we did 350 TAVRs last year and 280 surgical aortic valves. My less than 65 was less than 15%. There are people less than 65 that aren't going to live that long and should be done, but it's not half of them. If you're doing half of people less than 65, you are stretching the guidelines, and you're stretching, from my opinion, what's likely to be best for these patients. And we can't change the guidelines based on this, because guidelines need outcomes data. This is not outcomes data. This is just what people are doing. Now, patients all opt for TAVR. There's no question about that. At 71, I'd opt for TAVR, and I'm just below the European guidelines. I make the American guidelines. Again, I believe in TAVR. I'm going to do 10 of them this week. I think it's a good thing. But you have to remember that these people, particularly if you look at them and they've got small sizes and low coronaries, they are not going to get a second TAVR. They are going to fail at some point and get surgery, and that, at least in the current data, carries an increased risk. I don't think many people tell patients that.
I agree that this study is reflective of practice patterns, and certainly more data is absolutely needed to change the guidelines. But then you start to think about, where is that data? Where are we going to get it, and when are we going to get it? And will we get it in time? While in the meantime, we are treating, what's happening in the world, or what's happening in the U.S. How many patients will be treated before we may or may not make a strong suggestion to change?
Well, just remember, the low-risk trials still don't have long-risk data. We just saw the 5-year partner, and the mortality curves crossed halfway through, just like they did in partner 2, where surgery is now numerically better. Now, in Evolute, they're still spreading in favor of TAVR. But, what's going to happen when you get to 10 years? If the P3 curves still continue to move in favor of TAVR, and you've been treating people all this time, you may have done them an injustice from a survival standpoint.
I agree. Dr. Dauerman, any thoughts from you as far as, whether practice patterns will continue this way, or whether what the sort of data that we'll need to see a change?
The practice patterns are very interesting. This is my third study since 2018 on temporal trends in TAVR versus SAVR. And I know I always shift the conversation to less than 65, but if you look at now what the biggest chunk is of patients getting TAVR in the US, it's no longer the over 80 group. That used to be the biggest population segment. Now it's the 65 to 80 group. So it's the Dr. Reardons out there who are low risk 70-year-olds are almost uniformly 87% are now getting TAVR in the US. So that in itself is a real story because the average age in the low risk trials was 74.
Yeah.
So we really don't know long-term outcomes, and nobody can tell you TAVR or SAVR is better in a 70-year-old or a 64-year-old right now for 10-year outcomes. But I have a feeling that we all see this in clinic, that there is a tremendous pressure from patients to get TAVR versus SAVR based on length of stay and recovery time. And I don't see that going away. And even when I do tell my patients, look, I don't know what we're going to do for you 10 to 15 years from now, that could include a higher risk surgery. Often that conversation ends up in the same point. Just as when I try to explain to a young patient, you really should get a mechanical valve and go on Coumadin. That conversation never goes well. So I see this as something that's going to continue to grow. Right now in the US practice, about 10 to 15% of the population is less than 65 getting TAVR or SAVR. It's not a giant chunk. What I'll be curious to see is if that grows. And the one area that I'm watching out for most carefully here is real data on bicuspids, because this is where we see the bicuspid patient in this less than 65 group. And I have some concerns about the relative efficacy of TAVR versus SAVR and bicuspid. It certainly feels like a different procedure to me in my practice when I'm doing a bicuspid versus a tricuspid TAVR. And so I hope we can at least get a trial in bicuspids to help us guide us, and that will indirectly guide the younger age group.
Well, there are two randomized trials trying to be started up now, one in Europe with Stephen Wendecker and one here with Vinod Thurani and Raj Makkar. So, hopefully we'll get that data. The other thing I will say, Suzanne, is that we're saying SAVR and TAVR. All SAVR valves are not going to behave the same, and all TAVR valves are not going to behave the same. This is not going to be in a class effect. In my lifetime, I've seen several surgical valves that looked really great for about 7 years and then failed spectacularly. And so, I think that we have to be very careful that we are talking about these as classes alone, and they're really not. They're all going to behave differently. And Harold, I tell you, you're right. It's going to continue to grow. Patients want TAVR. There's no question about that. I had a 27-year-old in my clinic this week that demanded a TAVR. Did not do it. Told him I'd do a Ross, but came in demanding a TAVR. That's the kind of things we're starting to see in clinics.
And I think it's, you started with this comment, Mike, and I think it's a great way to end this conversation is really that this is going to come down to, heart team discussions and really counseling for our patients, because we're not just thinking about this valve, we're thinking about their lifetime management. And that's never been more important heart teams have never been more important when we think about kind of lifetime management and how we counsel our patients. So I think with that, I'm going to say thank you to Dr. Gupta, Dr. Dauerman for presenting your findings, Dr. Reardon for the discussion, and I welcome you to follow us on JSCAI on Twitter and YouTube. Thanks so much.